This is in Turkey. There's a case where they screen for SMA as a compulsory,
Yes,
mandatory situation. And if there is a positive, the government pays for it because it's more like an insurance thing.
correct.
Do you think something like that may work for cases like India or at least state wise? How was your trip to Bangalore so far?
Nice. Very nice.
Okay, so you've
Yes.
come just for the event, redress.
Yes, I have just come from TIGS redress.
Okay. And I think I've heard a little bit about your conversation topic there.
Yeah.
But maybe in quick summary, if you can tell our viewers also about your topic of conversation there,
Okay.
and how it went.
So basically, I was speaking in a section of population and community screening. So that was the topic of the session, and where Dr. Dalal delivered a talk on carrier screening, Professor Thelma delivered a talk on newborn screening. So I was speaking on a bit of the work which we have done from Organization of Rare Disease India on community screening and population screening, but as a rare disease as a public health topic.
Okay.
Um, rare disease is normally seen as a topic which is, very special.
Hmm.
But the idea was to bring in forward that these special conditions are also something that we see in even, regular primary healthcare centers. My talk started with us having a survey with the urban and the district healthcare centers where we actually asked very simple questions like, have you seen dysmorphisms? Have you seen pregnancy losses? Have you seen children who, with like families where there is a child who like an infant death, or some problems, or families where you have seen there are things like cerebral palsy, neuroregression, neurodevelopmental issues. And we had a survey in all these places where they said yes. So with the survey, we went to the government saying that, these could be rare disease as well, because it sort of the overlaps with, the manifestations. And when we did that, the government gives us space, saying that they will not be able to spend anything, but if we can come up with cheap screening technique in the population using their existing system, then they are willing to have a go to it.
Right.
So that is when it came to us that, we can use the ASHA workers, because the ASHA workers are going to all these houses. And if they can be trained to take a history, like, a basic history.
Right.
So the basic history would consist of how many children are there in the family, if there were any children who died, if there are any miscarriages that happened, if there was any IUFDs, or if there was any sort of developmental issues, regression, learning disability, anyone with who has difficulty in walking, who's to walk properly but can't walk, anybody who can't hear, has an eye problem. So every manifestation, but in a very simple way. And we train these ASHA workers to take a 3 generation family history just as a conversation, not really
Okay.
anything technical.
Okay.
Like, you go to your house, somebody, those old aunts or uncles who come and just chat up, that these are there, but in a methodical way, so that they can take the history for each of these families, and then present these cases to their respective centers, like the healthcare centers.
Right.
So on this survey, we actually had a point based calculation, and
Okay.
whoever had more than, say, 10 or 11, we put them as intermediate risk, and then we put the people who had many, like there were 34 points. So more towards 34, we put them as high risk.
Okay.
These high risk individuals were then brought and actually seen by doctors or geneticists like us. And then we would assess them that actually if there is a problem, because it can also be an accident induced, or other environmental causes, stroke, or some other things which can be there. So those were ruled out. The infection or other causes, nutrition issues were ruled out. And then if still we felt that it was something to do with genetic diseases or rare diseases, then we would do a workup for them, the genetic workup. So our state offers certain genetic condition testing for certain genetic conditions for free, and certain conditions we got a CSR, and we were able to screen. So till now, from January to about November, we have screened about 11,000
Oh, wow.
families. And of that, we had high risk of about 69 families. And of that, we could prove in 11 cases that it was actually a rare disease.
A rare disease.
Yes.
Wow.
So that was what I presented. We have a small project running with University of Salford for glaucoma, where we had a similar, we did not as a screening one but as a camp. We had two camps where we had 160 individuals from like sort of age 5 years to 55 years. And there we also looked at the intraocular, like the pressure in the IOPs, and the bilateral disc ratio, the cup disc ratio, because those are also the screening points for glaucoma.
Okay.
And there, if we got positive, then they went to these eye clinics where they were actually looked into with the dye and all.
Right.
And there also we found about 5-6 cases of 160 that came positive.
Wow.
So these are small screening things that we did as like basic population, not really a high risk population, but basically just in the general population. That's what I presented, like
Wow.
just questionnaire based, no fancy diagnostic, just basic.
And that screening, irrespective, still caught you those many families, almost
Yes.
11 families,
Yes.
that too in rare.
Yes.
That's
We got a number of Down syndrome cases, like
in this
we
in the
in
the
this
11.
cohort, but not
Okay.
in the 11. Like we did not
You don't
consider
consider them
the
rare.
Down syndrome
Okay.
ones, though we did do the workup for them because it came
Correct.
up in the
Correct.
population, but we did not count them as a rare
Rare.
disease
Correct.
because we could understand they have Down syndrome and it's
Correct.
1 in 600, so we didn't consider them for
Wow.
our study.
And that number is pretty big.
Yes.
And I mean, bringing that directly brings up the NIPS, NIPT conversation,
Yes.
right?
Yes. Yes.
Maybe a lot of them could have been caught if there were some sort of a screening
Yes.
at that level. But again, I think it's too much to expect all the families to
So,
have it.
frankly, still now, this is something I would say is a problem that we still don't have a mandatory maternal
Correct.
serum screening
Correct.
test, like, say, a fancy test like NIPT or a basic test like a dual marker. Say, even a scan. How many government hospitals are offering you a basic scan, like an NT
Right.
scan or even an anomaly scan?
Right.
So, these don't reach to even urban, most of
Correct.
the urban people who are not really over visiting certain types of doctors. So that is why to think, that Down syndrome still happens. Frankly, I've seen even in corporate hospitals Down syndrome children being born. So yes, we still are not there as far as the maternal serum screening or the prenatal, basic screening is there. And yes, tests like NIPT, if offered, might be very helpful in these cases.
Right. And this, I've heard another case. Maybe you can tell me about this. This is in Turkey. There's a case where they screen for SMA as a compulsory, mandatory situation. And if there is a positive, because the treatment costs millions, there's only one drug to treat that. The government pays for it because it's more like an insurance thing.
Correct.
Meaning you screen maybe 10,000 or
Yes.
1 million people. Maybe even if you find 5 to 10, you can afford because it's still like an insurance scheme.
Right.
Do you think something like that may work for cases like India, or at least state wise?
So I would say that India still has not been there with the carrier screening programs, unfortunately. But yes, it's coming up. Like we heard Dr. Ashwin speak, sir also speak about this carrier screening programs. The problem is the incidence in India for SMA is pretty high. See, what we have right now, if you see, we have more than it itself, like 300 patients in Bengal.
Oh, wow.
So to treat 300 patients would be
With that particular
with
drug.
that particular drug would be too much for the
Right,
government to
right,
ask. I think
right.
prevention is a very good way.
Right.
So like we test for thalassemia in the antenatal period. The IAMG, like the Indian Association of Medical Genetics, has directed to test for SMA as well. And this needs to be sort of regularized if possible. and that prevention might be a
Right.
useful thing. So the drug for SMA right now has been reduced to 10,000 rupees a while.
Really?
Yes, the Natco one which came
For
in.
India
Yes,
specific.
India has a drug which is 10,000.
Okay.
But understand this, that 10,000 is also too much money for the grassroots
Wow.
level people. They cannot afford 10,000 also. All right. So
Right.
uh, I would say India's strategy should not be about treating. Yes, insurance can come in. Who can
Some sort
afford
of a government
insurance?
insurance,
Some
right?
sort of a government insurance can come in. It can be as a part of Ayushman Bharat, or
Hmm.
these kind of schemes which are there,
Right.
or Pradhan Mantri Arogya Nidhi or
Correct.
something,
Correct.
Niti Ayog, something. But I don't feel that the government paying completely for the care of people will work in India. Like we
Right.
have disability, we have there.
There are
How
other
much of it
issues which
that
will
is
take up money
working?
first,
Yes,
right?
yes,
Right. I mean, when I heard this story for the first time, of course, Turkey is smaller. It's like, I don't know how big, maybe it's less than size of Kerala or
yes,
something like
yes,
that.
yeah.
I always like overlaying our map over these other countries'
These other
maps
countries,
to
yes.
get you context. So if Kerala government at some point decides to do it, they can. But again, only at a state level,
So it
like that.
see, these would be a state. See, health is as like anyhow a state
State level,
concept.
right?
It is not a center concept.
Right.
Center can impose guidelines. So center
Hmm.
can say that these are the things you have to do as a
Hmm.
part of the policy. But state, whether the state will do it or not, is a state decision.
Hmm.
Let's not speak of SMA only. Let's speak of
Hmm.
simple things like
Hmm.
thyroid.
Hmm.
Has Are all state government hospitals screening for thyroid? The answer is
Hmm.
no.
Hmm.
It's no. So if we cannot screen for a simple, and if you say that tests are costly, it is not. It doesn't cost
Thyroid is
much,
not,
right?
yeah. There's this whole success story called
Yes, and if
Thyrocare
you
around
say
just that.
so if you
Yeah.
say drug,
Right.
what is the cost of a thyronorm you are taking? It's nothing, right?
Right.
So
Right.
if that is not working in India, how do you expect
Correct.
SMA to work?
Right. You're right. I think we have a long way to go, but at least
Yes.
there's some
So I
direction.
would say we should advocate more for prevention and
Hmm.
awareness, because at least then what happens is that you reduce historic patients.
Correct.
And if we can reduce the number of patients, then maybe the government can take up. There's a very little amount. So,
Correct. At
through
least get
some
that incidence
insurance,
down, and
yes,
then you can
then
maybe
maybe the
spend better.
government can think of it.
Makes sense. Perfect. And in your case, when you did this population genomics, again, Jan to November is a super short timeline.
Yes.
to actually screen 11,000 families, how many ASHA workers was that?
So we had 166 wards
Wow.
where there were about 350 ASHA workers.
Okay.
So I don't know how much you know about it, but one ASHA workers covers 3,000 families. That
They,
is
they
what
almost know them pretty much.
yes,
Okay.
that is their area. So
Right.
when I went for these, when we were mapping the ASHA workers to the families, I was told by the municipality that one ASHA worker is supposed to cover 3,000 families.
Wow.
So, and we had set a date of 10,000 in a year, and we have this as a 3-year project.
Mhm.
So in 3 years our intention is to screen 30,000.
30,000.
Yes.
Wow. And you're already kind of ahead of
Yeah.
schedule.
Yeah. No,
That's
so
great.
it gets, I'll tell you. So the ASHA workers are not just doing this, they are
Hmm.
doing other
Other
things
things,
also.
correct.
So there are months where it goes down. So
Hmm.
that was the idea which was given by the CMHO who is in the municipality, that there are months like malaria, dengue months, like
They're focusing more on
they
that.
will not do rare disease.
Right.
They will only focus on malaria, dengue. And then these ASHA workers and medical officers are also undergoing a number of training, like say
Ongoing.
tuberculosis, say other things, vaccinations, and right now anemia mukt Bharat. So they are trained a lot on many things. So it's not like really that every time they have the time. So the way we do it is, in some months we are ahead, in some months we are behind.
Wow. Again, I always like drawing parallels across completely different industry, completely different use case. But one data point is medical reps, right?
Yes.
In pharma,
Yes.
the math works exactly almost like this. There are,
Yes.
I mean, there's a big number of medical reps, but the rough number is no matter what brand or company you belong to, On average, one medical rep covers about 100 to 200 doctors.
Correct.
That's all. So
Yes.
those are their area and their doctors,
Yes.
and they keep getting trained on new drugs and they keep going back.
Yes.
And so again, it's a very weird parallel,
No, it
but
is a right
right,
parallel because these, so the way it works is this ASHA workers are responsible for these 3,000
right,
people.
right.
To the extent that while we were doing all this, like, if there was a pregnancy in one of these high risk families,
Mm.
they would call up. So we have these WhatsApp groups and all of that. They would call up and say, Didi, यहाँ पे ना like pregnancy है, आपको इसको जल्दी से देखना पड़ेगा.
Wow.
So, so they know it so well right now,
Right.
and they were trained. Like, we didn't achieve this in one day.
Correct.
They were at least trained for 6 months before they could actually be on field. So we started initiating this into 2023 January.
Wow.
And the implementation, them being on field, was 2024 January. So
Wow.
there had to be, because even the forms which we were, the questionnaire, these were all had to be in their language they were comfortable in.
And is it like paper or
It's
is it?
it's right now paper, but we
Right.
intend to make it app
Right.
based
Wow.
sometime in future.
That's great. So you have WhatsApp, you have app. I think this can scale really
Yes,
fast.
it can. It should.
Right, right. That's great. Now, coming to a very different part of the story. So, I was reading a little bit about, of course, we are in the same space. I'm in the genomic space, and somehow we don't get to meet genetic counselors as much.
Yeah.
So, I'm happy that this is happening, and I'll ask you all the questions that I
Sure.
have about this. So first thing that I was doing is when I was trying to understand how your day probably would be going by, again, from what I could read, you stand between hard science and also human emotion, because you're watching and seeing these patients, and
Yes.
often you're the one who delivers good or bad news in most cases.
Yes.
How did you decide to get into this field?
Okay, I didn't decide. So I think
Okay.
my journey was very different in the sense that when I was doing my PhD, I didn't even hear the term genetic counseling.
Okay.
All right. So my idea was always to do something where I could do translation research. Like, in the sense, I no matter how much I loved basic research and I had an inclination towards it, I did not really enjoy it, because at the end, like, we were a human genetics lab. And at that time, there were no such commercial labs available. All right. So we used to often get samples where we were asked to screen for Wilson disease, or, get a IBD, like, get like a thalassemia genetics done.
And even the numbers used to be low. I
Much low,
propose, yeah.
much low, because at that time it was not possible only in this way. So labs, there were specific labs working in specific diseases, and if you happen to be in these labs, like all over India, there was these few genetic labs that were there who was doing research on those specific genetic diseases, and if you were in those, you used to get some
Correct.
samples, and there was no formalized way of doing anything. So that is where we started, and I started as a cancer like, molecular biologist. Like, I in my PhD, that's what I was doing. But I had a side project with recurrent pregnancy loss, and also sometimes these samples used to come in where, my boss had a special inclined towards these genetic conditions, and we were asked to just do it. So it was not really a part of our daily work, because I was into cancer genetics at that time, but we used to do this. And when we used to see patients, at that point, it felt that, okay, fine, we are just, giving a sequence, or we are saying something that might help them later. But when I moved to my PDF, when I went for my postdoctoral fellowship, what happened over there was we could actually see a sort of a relatable, like, I first started working over there with HIV patients and all of that. Okay. So in there, I got sort of pushed into more of the patient care and the patient facing thing. So one of my boss was a pharmacogenomics person. The other one was basically, under my other boss was actually a clinical geneticist, and he was looking after this a Jewish clinic. That is how I got pushed, and I was basically working on brain development and neuromuscular development and all of that.
Right.
At that point, I sort of got pushed into taking patients' history, etc., etc. And my boss said that you have this very nice way of taking patient history, and patients seem to open up to you somehow. Why don't you do this course,
Right.
and why don't you get certified?
Right.
So that is where things sort of shifted and changed, because I knew my genetics very well, because I was coming from a population genetics background. I was coming from the entire genomics background, and there it connected with me. It really connected with me, that patient care and genomics and all of it. So I did my clinical genetics thing over there, got certified, and then when I was then in a pharmacogenomics lab, and we were looking at HIV patients, morphines, etc., along with all of my training.
Right.
Then when I came back over here, like when I had to come back over here, I again came because of a personal cause, and
Back to India. Right.
back to India. And I didn't come up with a job. Like when I came back, I just came back. And I was actually offered a job in a hospital where I was asked to actually standardize, assays like
In the
karyotype and
lab.
etc.
Oh
in a
wow.
lab in a government hospital.
Okay.
And I said, oh wow, this is something I would love to do,
Right.
because I have this
Right.
training also, and it actually summarizes both.
Right.
So that's how I started. And from there, because it was a government lab, we started setting up things. I was able to set up things. We had started giving on reports. Now the reports needed to be explained, because there were
Correct.
no doctors who were
Right.
there to talk to these
Right.
patients.
Right.
So there my training came in from outside, because I had just come. My plan was to actually go back.
Right.
I'd come for a personal crisis.
Right.
The idea was to spend time, do whatever was needed and go back.
Right.
But I sort of got stuck, and then then I realized that I should have the Indian certification also. So I did my certification, because
Okay.
I was in a hospital.
Okay.
They said that it's a requirement, so we did it.
Right.
And then it just flowed in, then I was the only person in Calcutta at that time, and there was another girl called Sana. So, we both were just there. And between both of us, we were like seeing a lot of patients suddenly,
Pretty
because there
much
was
all
no
the
one.
patients
Because
of
there was
that
no one in
region. Yeah.
Calcutta at that
Right.
time.
Right.
So, unfortunately, Sana went back. Like she had to go back to Dubai, and I was the only person left. And I sort of, you can say, got stuck. So I didn't choose the line; the line chose me.
Yeah,
So
the line chose you.
GC
Yeah.
chose me.
Yeah.
All right.
Yeah.
And I started sort of to, and when I decided I was not going back, I actually saw one post from Mr. Prasanna Shirol regarding Organization of Rare Disease India and how they were functioning. In US, I had seen patient support groups, and I was amazed to know that here there was something there.
Right.
And I actually reached out to him saying, "Sir, can I, be of any use?" So it started all there. So I didn't make any special effort to be in this thing,
Right.
but it's just one thing happened after
Yeah.
other, and I would say it was almost destiny.
Awesome. Because again, like I said, I haven't met a lot of GCs firsthand, but at least from what I looked up profiles, and because I end up meeting people by way of meeting the labs and they happen to be there, sometimes they get called in. I don't think a lot of them have the actual core lab side of background, right? This is a very rare scenario
Yeah.
where you've actually gone to the lab, spent time in the lab, and then you've
Yes.
chosen this.
Yes.
Yeah,
Yes.
I'm right then. So that insight. So yeah, that's what makes you, I think, very different from everyone
Yes.
else in this approach.
Yes.
And wow, that's a really, I didn't know.
But
This is a
right
great
now,
story.
many people are coming in who are genome analysts who are doing GCs
Right.
as well. So right now, you see a mixture. So
Mm.
there are people who are just trained in genetics and MSc genetics and genetic counseling, and they are coming in. There is also a significant amount of people who are genome analysts, PhDs, who are also coming in. But when I had started, there were no such people. These
Right.
kind of people were very less.
Right. In an alternate world, we would have still met you as a lab director,
Maybe.
probably. But this podcast would have still happened.
Yeah. Destiny, I
Yeah,
guess.
yeah, that's very nice to know. So I had another question for you. So, uh, while you're speaking to patients, now you'll face patients, I think almost every day,
Yes.
right?
Yes.
And there's a lot of times when, again, this is something I was looking up and reading and realizing I don't know how much of my future is dependent on what's already in my DNA and
Correct.
how much of it is actually my lifestyle. Now I don't know, because the problem of knowing too much is also a problem, right?
Yes.
So because I'm in genomics and because I read what I read, and I work with customers that are into cancer genetics and rare diseases and genomics literally every day,
Mhm.
uh, it's a terrifying question in my head. So if it's already in my DNA, can I do something about it? But or is it too much on my lifestyle? So do you get questions like these?
Yes. I'll give you two examples of this. So, we had a prenatal case. Like,
Mm, mm.
this fetus showed some risks. We did a prenatal diagnosis, and we got a sort of big deletion
Oh wow.
in a particular gene, which
Mm,
is associated with hereditary sort of neuropathy. All
mm.
right. It's basically CMT.
Right.
All right. And many a times today, Dr. Ashwin Dalal sir was also saying that many a times when these parents come in, na, the mother and the mother's family comes in, the father never comes in.
Is
Many a
it?
times,
Okay.
and I have this habit, of asking
Mm.
that, where is your husband?
Mm, mm,
Like,
mm,
this is a news I have to give. And
mm,
because this was, I don't really like to, do a directive counseling. A GC shouldn't do. But in India, things work differently.
mm,
But in here, when I saw the patient and we understood this was a neuropathy that will develop eventually, right now, the fetus has, really nothing at this point, and this was just an incidental
mm,
finding. I really wanted the husband also to be there.
mm,
And in the course, because this was an incidental finding, I started asking that, is there anybody in your family who walks like this?
mm.
And then she says, my husband walks like this.
Wow.
Like my, husband has issues with walking.
Mm,
I said, can he come? I
mm,
still did not say the news. I said, I have
mm,
some news,
mm,
but I need your husband to be
mm,
in this scene if he can come, or
mm,
I want him to be online. Like,
mm,
in some form, I want to see your husband while I give this
mm,
news. So she said, okay, ma'am, I'll come the next day. I'll bring him. He can
mm,
come. He's in
mm,
office. He lives here only.
mm,
He just didn't come, but he can come. So the husband comes and he's limping,
mm,
and when he's limping, I see his feet has this this curve,
mm,
which is like a classical CMT curve. All
mm,
right. And
mm,
everything is there. And when he sits, I just ask him few questions, like, that did this start from like 15, 16 years? Do you have cold sensitivity? Was it progressive? Do you have tingling? And he says yes to everything.
mhm,
And when he said that, and I said that, that your fetus exactly might have this, and you
mm,
probably have a diagnosis of this,
mm,
he started crying. The first thing he said, madam, I thought, this happened because I did something wrong to myself. I used to smoke a lot when I
mm,
was a child, and I
mm,
thought that smoking did this to my, I had some nerve damage because of smoking.
mm,
I never understood this was a genetic condition which would have happened even if I would have lived a completely normal life. So he got a diagnosis which he was not even looking for. All
mm,
right. And it is so important for us to, spend some time in such situations. Understand, this man is almost 35. He never knew why he walked
mm.
completely all right as a child, and he never knew why he was
Wow.
walking this way. And we have a fetus with a similar thing. And now, we were counseling that the fetus would have the same thing. And then, the wife was like, she was all right. She was like, it's okay if, but my child is still, all right. He's all right.
Mm,
But this man is saying in a different way that I don't want my child to face what I
correct.
am facing.
Right.
So you see, this is such a dilemma. This is not a life threatening condition. It
Mm,
might be a life limiting condition,
right.
but it's not a life threatening condition. So I said that you don't have to take a decision right now. Please, let's talk again.
Mm,
Let's talk again the next day.
mm,
You take some time off, go and talk amongst yourself and come back.
right.
So, it's a huge realization. So this is one case. The other case I'll tell you is of a breast cancer. All right, this mother had breast cancer. She had two daughters, and one was 31. She had a little girl, and the other was just getting married. Now she works as a software engineer. This 28-year-old girl comes and says that, I have heard Angelina Jolie. My mother has breast cancer. She was never asked to do any testing, but I want to test. I don't want to get married or have children if I have the risk. So we counsel her. We say it's not that you cannot have a family, or this DNA thing does not depend on whether you, if you want to have a family, you can go and have a family. You can do these testings. We can test your mother, and if your mother something comes up, we can test you if you want, and you give her the entire lot. Right. So her mother gets tested very willingly, and we do a targeted testing for her. Our sister, she does not have a mutation. The sister has it.
Oh,
and
wow.
This whole diaspora of things,
And you
the
do this every
emotions.
day.
Yes.
Wow.
And see, this whole diaspora of emotions. Now the sister is very scared that what
Right.
will happen to the little girl
Right.
she has.
Right.
And you would imagine this other sister, the little sister, to be happy, but she now feels guilty
For actually
because
finding
she
out,
says
yeah.
that I initiated all of this.
Right.
So even if you test, even if there's a surveillance, it's just not about delivering a genetic report or doing a genetic thing. So as genetic counselors, we actually face a lot of these emotions. Few of them are guilt, few of it is closure, few of it is we have so many happy families, who actually then have a very healthy baby. One of the other case, a very short way, I will say that these parents, they had a child who had a pediatric leukemia, and the child succumbed. When the child succumbed, before the child succumbed, they were asked to do a bone marrow. And when they wanted to do a bone marrow, they actually realized that the child was not the biological child of the parents.
Oh, wow.
So they actually had done an IVF, and somehow the IVF lab actually did not use the parents' gametes.
Wow.
And then they went and sued the IVF lab. All right. And but they still wanted to go on and have a
Second
child.
attempt, right?
Now fighting this emotion, just imagine,
Wow.
out of nothing.
Right.
So you get to see so many stories every day. And I feel genetic counselors are these people who actually handhold these families every day. It's just not a job, it's just
Right.
not a patient coming in, it's just not a job. And now this, like, just before I came, like, here on 26th, on 25th, they delivered a baby,
Oh,
and a
right.
perfectly healthy
Right.
baby. And
Right.
even we get very happy when these things happen. It's
Right.
almost like, our own people are delivering
Right.
babies.
Right.
So it's a journey. We are in their lives, they are in our lives
Right.
for a certain amount of time.
Right.
And there's a lot of emotions that are there. It's just not one emotion. That it ranges from happy to being guilty to being anxious to being angry. It's all the emotion a person can have.
Wow. Yeah, I am moved, definitely. I don't know how the rest. I'm gonna take like 20 seconds to like think about this, but it's a hard job. I think
It is
that I can see.
it is mentally draining. um, it's mentally draining because it's emotionally draining at times. And these are the good stories I'm saying in that way. There are stories where we couldn't help. Like, I'll tell you. So I work for a trust hospital, and there was this particular person. He works in a leather factory, and his education level is not more than class 4, class 5. So their first child, there's a genetic condition called Lay syndrome. So the first child died. They didn't know why. The second child, I was able to diagnose. And by the time I could diagnose, they already had a third child, which was
Wow.
born. And, because we did the second child, we diagnosed the second child, I tested the third child as well. And this third child also had the same condition.
Oh, wow.
And we knew it was just 6-7 months. All right. And this child gradually passed. So when they came back to the hospital at the last stages, I was sitting with this man and the lady, the mother, and even I was feeling lost because it felt that somewhere the system does not work. We could have prevented certain things, and it felt that system couldn't work. So I was also quiet, but I was there. Even the pediatrician was sitting there because sometimes it happens that you don't want to actually it's bad, but there's nothing to do. The
Right.
child was passing off, and this woman comes up. She realizes that I am probably very sad, and I'm just sitting. I was just sitting with them, and this person comes up, this lady comes up, the mother comes up and says, "Madam, thank you." And I actually had tears in my eyes saying, "Why are you thanking me? I couldn't help you in any way." He said, "No, ma'am, you did help." I said, "How did I help you?" So she said that, every time when we had a child, the child was fine at certain time and then started regressing. We thought it was a curse. We thought something was happening. We thought a lot of things. But and we were very scared to let the baby go because we somewhere understood the baby will pass off, but we didn't know why.
Right.
Here, even before the child had any symptoms, you told us this child was having this condition.
Right.
And we know we could give the best of everything. Every day we celebrated in a way that I wanted to celebrate this child as
Wow.
they will live. And we knew this time that this child will
Right.
go. But madam, I don't feel bad because I did everything. I went to every place I wanted to go with this child. And it was a learning experience for me also, that we feel that we are giving bad news. And then she said, maybe it's my destiny that I don't have a healthy child, but I also know now that even if I adopt, I did everything for this child, and I don't feel bad about it.
I don't have regrets.
I don't have regrets. So
Wow.
your patients teach you so much that you sometimes you are overwhelmed by the fact, like, we are just giving some genetic data to them, and you are trying to make a beautiful world, but beautiful world can be there in a different way also. So and these families, with the education level they have, you might not think they will say such things.
Right.
And when they say, and it's a learning, and you are holding on to things which are actually not important.
Wow. this is these are great stories. I mean, the fact that you live this every day
Yeah.
is what makes
And
it
it's
very
draining.
special.
It's sometimes draining. So sometimes, like today morning, at the DIJS campus, I was just saying to somebody, like, I in the morning I woke up, the campus was so calm. There was no phone call, my connections were not working. So I just was sitting, and we also need to. There's a significant amount of emotional fatigue we have because of all this.
Right.
And I feel, as genetic counselors, that point is also very important, that we also need to, let go of this emotional burden that we face every day.
Right. And I mean, you're already doing a job of a therapist and a doctor
Yes.
and everything in between.
Yes.
So I think that's another way of defining a genetic counselor,
Absolutely.
right? You're a doctor and a therapist, but not both and both. So
Yes.
it's great.
We're
I was
somewhere in between.
somewhere in between. And I picked up one interesting thing from your profile. There's a patent in head and neck cancer.
Yes.
Can you tell us about that?
So this was a reflex work of my PhD. So I said I was working on cancer. So for my boss was extremely interested in head and neck cancer. So that in head and neck cancer there is they take a decision. If it is metastasis, they will cut out the entire jaw. If it is not metastasis, they will actually give you radiotherapy
Right.
and preserve as much as possible.
Right.
So we actually, my boss, Dr. Shushanto Roy Chaudhary, and there is another person who's a bioinformatics person, Piyush. We actually came up with a biomarker. This biomarker was a 51 gene signature, which we were thinking of, which we had to say that whether this will metastasize or not. They take a small biopsy, they run it through it. So we did this at the time when transcriptomics was not
Was
there.
not even a
Yes,
thing.
it was
Right.
not even a thing.
Right.
So and then we did the PRS and the rock curves and all of that, and it was a signature that we patented. It was supposed to go a platform transformation and have it in the as a kit in the
Right,
industry,
right,
but that
right,
didn't happen.
right.
It was a CSIR. The funding agency was CSIR, but we were able to give that 51 genes, like sort of protein signature, some of it upregulated and downregulated for if this cancer would metastasize or
Okay.
not, so the clinician could take a decision on the surgery based on that.
Right. And would you have done it on a
Uh,
proteomic
it it
based
it
assay?
was it was basically a transcriptomics base. It
Okay,
was
so
the
you would
RNA.
actually do an RNA assay.
Yes, yes.
Okay. So you've seen this entire world change over the last 10, 14, 15 years, especially when you've been in your career. And you've come from a place where you mentioned that you were in one of the very few genetics labs which used to get samples because they're known only for that. From there, we're in a world where every city, almost pretty much every, even tier 1 town, can at least collect a sample
Sample.
for a genetic testing, if not for testing in the same place. And now some of these are even offered as commercial products, to the point where they're going out there educating clinicians,
Yes.
especially NIPS or any other genetic testing assays, and even lifestyle products like just know your genome, have an idea,
Yes.
keep it with you. So
Yes.
maybe you can talk to a GC at some other point and look through it together. So where do you think we are going? We've come from there and we are here now. So what do you think the future is going to look like?
Okay, this, when we were young, we were supposed to write this essay. Uh, how do you feel science is? And there was a dialogue. I remember my mother actually made me write that science is like a double-edged sword. I don't know whether I'm too
It's
old,
still applicable today.
whether
Right.
I'm too old, but this was the first line my mother used to make me write, that when something like this comes, right, that science is a double-edged sword and it can do
And
good to people. And she
right,
actually said this from the point of view of the atom bomb and the nuclear
right, right,
energy.
right,
But
right,
I feel the same thing
right,
is with genomics.
right.
Overusing something
Mm,
might have some implications. So we don't realize sitting in these cozy chairs that
mm,
what happens in the rural areas. So even a carrier is, if it's a female in the patriarchal world we live,
mm,
leads to a lot of discrimination.
mm.
All right. No matter how much good it does, also understand how much bad it is
You're
doing.
right.
All right. So that is why we need ethics committees and we need protocols and guidelines, so that we understand that whatever science we have and whatever, this quantum leap we have is being used in the correct way. Number one. Number two, it's awesome when you can give a diagnosis to a patient and the patient can have a healthy life or has interventions, management, increases the quality of life. But we also need to understand, like, there are quacks in medicines also. There are people who are overutilizing or over hypothesizing certain things in genomics. uh, Genomics is not a magic tool
Mm,
that you do it and something comes up.
mm.
It's not something like that, correct? So we also need to understand that the limitations also need to be spoken. Like, we are saying it like a Aladdin ki magic chirag, आप जेनेटिक टेस्ट करो और आपकी जिंदगी के बारे में सब कुछ पता चल
Mm.
जाएगा. But people who are in the lab or who are actually working, who are very much into it, um, understand that every test you do, no matter how great the test is, had 200 other limitations which you are missing,
Right.
right? To the clinicians, often genetic testing is black and white, but genetic testing is anything but black and white.
Right.
It's gray. When it comes to personal genomics, we still don't have the benchmarks as
Mm,
far as India is
mm.
concerned. But there are so many people selling the test. So I wouldn't say there is anything wrong with, genomics being marketed as a consumer product. But I would say that it is time that India comes up with guidelines and quality.
Mm.
You have NABH and NABL.
Correct.
So there
Right.
needs to be a, and these also work for genetics labs, but there
Correct.
needs to be a specific genetic quality assurance which is there as to what you can offer to a patient and what is the minimum quality required and what cannot be offered to a patient.
And what cannot be reported
What cannot be reported, what can be reported. Also about the implications of these reports. When we say that, say simple, I'll take it a very simple thing, that you are thalassemia carrier sitting in a urban place, you might not realize what happens in the remotest of village. Nobody will marry this girl. So when we say this, we feel carrier, the report is very good. There's nothing, it's just a carrier. But it's not just a carrier. For that family, there are a lot of other social discrimination, or even if you say it's a X-linked disease carrier, there's a lot of within in the patriarchal world, there's a lot of things. Also, misuse of these reports. PCPNDT Act says that you cannot report a X-linked disorder in that way.
Correct.
But there are people who might utilize it in a very wrong way. But my question also lies here that, in ultrasound also you understand that it's a female or a male.
Right.
And you actually don't need to, do a test also. You see certain things in ultrasound and you know what it is.
Right.
And those who know, they know.
Right.
So every test, every screening test has certain limitations and certain guidelines that are imposed on them, like in ultrasound. I feel it's time that we impose those guidelines for genetic diseases as well. We know still there will be loopholes, still there will be people who will misuse it, but at least you can curtail that as much as possible.
Right. And we are a large country, I think it's about time.
Yeah. And we should, with so much of genetic testings happening, government recognizing genetic test, and with right now many government places getting a grant to do these genetic testings, it's high time that we have a quality assurance.
Right.
Which is
There is though diamonds scheme which actually empowers molecular testing.
Yes.
At least in oncology, which is, I think, one of the most advanced, well utilized grants, because at least in the larger centers like TMH, there are multiple TMHs now, and then there are other cancer hospitals which are private, not fully public.
Yes.
They can all sort of get into this program, and it's like an insurance for molecular tests.
Correct.
Pretty much the government pays for these tests as and when they are done. But you rightly said, the quality assurance programs,
there has to be some kind of a quality guidance programs and time to time check, like they do for these NABL
like
tests,
annual audit.
Yes, the audits has to be there. Your controls validations has to be there. Those I feel it is high time India has this right now.
Right. Because governments like UAE, for example, put out a big news very recently, and I've been there. Like especially in my last trip, I've been there, and I've gone to. You won't believe there's a police department. From the outside, I don't want to name the city, but it's that city's name, police department, and it's like any commissionerate office that you would see in India. And the local partner is taking me in for a meeting, and I kept asking him, are you sure there is a lab inside? Like, are you sure? And like, yeah, just come with me. Like, you don't understand how serious this is, a big lab. And I'm still wondering, maybe it's just like some sort of a blood test lab, or maybe forensic even. That's the closest I could get to. And very reluctantly I said, fine, let's go. And I went inside, and they were having a National Day celebration, so there was a lot of local performances happening, art performances happening, and I'm still wondering, where am I going and what is happening. And I go, and in about 10 minutes 8 people come. Very courteous people, very friendly people. 8 of them just assemble. Most of them are locals. Only 1 or 2 people are actually non-locals who are part of this team. And they start explaining me what they do. And it was so surprising to see what's happening over there. They have something called National DNA Database. Now, now I don't know how much of this I can put out. I haven't mentioned the country, so I think it's fine.
It's fine.
So this particular country takes samples from pretty much everyone on a daily, ongoing basis, and they keep a record. They scan, and this is through an FDA card, like a DBS card. And there's an automation which actually punches the FDA card, drops the punch into a PCR plate which already has reagents in it, and takes that through a screening test and also amplifies it and goes downstream and also prepares the entire STR analysis report. It was so good and so automated. When I walked into the lab, there was one person, and that one person was just loading FTA cards into an initial device. And there are two liquid handlers which basically do all the way from punching to dropping it into PCR, pushing it into a plate which is ready for amplification. The only other thing that person does is take the plate,
And
put
put
it
it
into an
there. Yeah.
amplifier which is in the next room. And then I go to the next room and another automation which basically is prepping the PCR plate.
Okay.
Within just two people, and really large lab with just two machines, they do about 10,000 samples a month.
Oh wow.
And this is just like every day. They're just very matter of factly saying that, yeah, this is what we do. And here I'm wondering, man, this is so advanced. And that is why I realize, right, like there are same countries today are offering genetic testing programs at the population level, and they're saying even before marriage you could just like
Yeah, because
get
see, the
tested.
carrier screening program which you were talking about, say in the Middle East, they realize that if they have to have a healthy population with so much consanguinity there, if they don't screen before, they will have a population which is completely unhealthy by a certain time. So it is important. And the database that you were talking about, that identification database, STR, I think FBI also has a similar
Mm, mm,
yeah, the
mm, mm,
FBI
mm,
actually has a
mm.
similar program. Many advanced like countries actually have a DNA database.
And it's run so well. It's run so well because labs, I mean, I see labs pretty much every other week. That's the job, right? I keep going to labs, and we work with them hand in hand. And here it was so good that to get into the lab, for them to show me what they're doing, they had to take my sample, put my test also into the lab,
Oh, okay,
so that you do this thing called basically you remove my DNA from that list. So
okay.
in case there is some sort of a contamination, they know it came from this and it's removed. So I had to give my sample. They took the sample, they quickly recorded, pushed it into the test, and then they said, "Yeah, come."
Oh, nice.
And I'm like, "Wow, this level of quality assurance and can be managed without having 200 people in the lab."
Yeah, because number one, they thought it through that
Right,
automation, and these cases you probably would need lesser amount of people so that
right,
the contamination doesn't happen
exactly, exactly.
naturally.
Just literally one person, and it's not hard for us to do it. It's not hard for us to set this up at the state level. It doesn't even cost so much now in this
Correct,
day and age.
correct.
And
But
automation
the
is a
intention has
solution
to
there.
be there, right? It's all about whether the intention is there or
Right.
not.
I think we've done quite well with IT and software in some way or the other, but telling our states about importance of these things, I think you're doing a terrific job. You're going across the country, you're talking about these things. Hopefully that'll go through the right channels and eventually these things
Yes,
happen.
hopefully.
And and thank you so much for this kind of work and getting into this firsthand.